Hello, my name is Mary Sweeney. I am the Advanced Practice Provider Educator at White Plains Hospital and a student in the A.T. Still Doctorate of Medical Science program. Today, I will be presenting my implementation project focused on the effect of simulation-based education on long-term retention in healthcare. For this implementation project, I will be incorporating the scoping review results into the design of a simulation curriculum for a mock code series. This will include applying the retention test interval of 3 months, which was found to be the most effective in the review. The objectives for today's presentation include discussing the current state, reviewing simulation-based education over traditional methods, understanding the key stakeholders, and discussing the curriculum design. At our institution, the critical care team responds to all code blues hospital-wide. Feedback of code scenarios has shown that there is disorganization, particularly with a lack of leadership and assigned roles. An effective code team improves patient outcomes by avoiding delays in care. The use of simulation can empower the PAs to act in a leadership role. This in turn will improve communication, organization of assigned roles, and the care provided to patients. Traditional learning through didactic education is needed to create a baseline fund of knowledge. Simulation-based education has become an approach to supplement this learning and is now seen as the standard of training in medicine. A simulated environment provides trainees with additional exposure by practicing challenging clinical situations without increasing the risk to patients. Evidence has shown that simulation has positive effects on the immediate retention of skills. Deliberative practice, including personal reflection and individualized feedback, improves these positive outcomes. A significant decline in skill retention has been observed within 6 to 12 months, but can occur as early as 3 months after initial training. In my scoping review, all studies showed the immediate improvement of skills, with a decay as early as 2 months later. Longer retention test intervals were associated with a greater decline in knowledge and skills. The key practice area will be the critical care department, including the code team. Key stakeholders include administrative leaders, physicians, PAs, nursing, and respiratory therapy. A small work group will be created to develop curriculum, learning objectives, and didactic education for the series. Departmental meetings will be used to communicate the importance of the series and the potential impact it will have on patient care. Scheduled simulation dates will be communicated via email and signage in the unit. Engaging nursing and provider leaders will require an interdisciplinary approach. The small work group will provide technical expertise of code situations to design the program. As the APP educator, I will serve as project manager by overseeing the program initiation, design, planning, and execution. I will work closely with the nursing and provider leaders to schedule repeat simulation sessions. Given that one of the main objectives is for the PAs to take on a leadership role, the lead critical care PA will be the main facilitator of change, and her support will be crucial for project success. This past year, the hospital achieved CMS 5 stars for the second consecutive year, demonstrating an institutional commitment to excellence. The institution is a non-teaching hospital that allows for direct contact with senior leaders, giving employees a unique opportunity to influence change from the ground up. However, despite this commitment and ability to change, the organization still faces challenges. By meeting with the proper key stakeholders early in project development, the need for PA leadership during codes can be addressed as a direct solution to the current disorganization. Strengths of the hospital are its positive culture and strong administrative leaders. Weaknesses are disciplines working in silos and the deficit of code leadership skills within the current PA team. Opportunities include improved teamwork and communication, and lastly, a potential threat is the lack of support for PA leadership during codes. The main objective of the mock code simulation series is to improve communication and organization during the code scenarios. The series will be in situ within the critical care unit for convenience and accessibility to staff. A low-fidelity mannequin paired with a SimPad will allow for real-time feedback of skill quality. Pre-briefing will include an introduction, possible limitations of simulation, establishment of a fictional contract, and confidentiality. Scenario 1 will have shockable rhythms of VTAC and VFib, while Scenario 2 will be pulseless electrical activity progressing to asystole. This image represents an organized code with effective assigned roles. The physician and respiratory therapists are positioned at the airway, 2 compressors are rotating performing compressions, an RN is giving medications, and the recorder is keeping track of time and events. The PA team leader is positioned at the head of the bed in front of the monitor to communicate with the team, assess the patient's rhythm, and provide cross-monitoring. After the simulation concludes, a standardized debriefing will be used to reflect on the experience of the participants with use of personalized feedback and didactic education on effective management. An evidence-based mock code checklist will be used as an audit tool to measure performance objectively for each session. A short electronic questionnaire will be answered by participants after each session to provide feedback. Quantifying measures for each scenario will be recorded by the simulation technician to determine the effectiveness of the care provided. For the VTAC-VFib scenario, time to first dose of amiodarone and time to defib will be used. For the PEA asystole scenario, time to first rhythm check and first dose of epinephrine will be used. These metrics will be measured and compared at each repeat session to determine if skills were retained at the next session. The SimPad Plus has the capability to provide quality feedback of performance during the mock code. The skills of defibrillation, compressions, ventilations, and blood pressure or pulse checks can be actively reviewed in a real-time report of quality during the debriefing phase. Lastly, code leadership and communication of role assignments will be assessed to provide individualized feedback to trainees. The initial minimum requirement will be 4 simulations per year or every 3 months, which is the retention test interval recommended from the scoping review. The performance of the sample population from critical care will be recorded at baseline and repeat sessions. As skills improve and are maintained, the participation requirement will decrease to every 6 months or 2 times per year. In addition, code blues in the hospital will be observed, followed by immediate debriefing utilizing similar deliberative practice techniques from the simulation sessions. This will aid in translating the knowledge and skills gained in a simulation environment to real-life scenarios. Getting research into practice requires addressing potential barriers and enablers to evidence utilization. One enabler for the series is administrative leadership that is dedicated to improving codes. An obstacle is the extrinsic factor of availability to participate in repeat mock codes with an interdisciplinary team at the recommended retention test interval. Organizational support is needed to create protected education time for trainees. Given the low volume of staff from one department for the project, quarterly check-ins will be obtainable and welcomed. The project team will help to monitor improvement or potential opportunities. Real-life code blue monitoring and debriefing will also allow for frontline staff to provide pluses and deltas of the current model. Open communication will be encouraged, and suggestions will be directly incorporated into future training. As new hires become acclimated to the ICU, they will be required to complete mock code scenarios as part of their onboarding process. This will provide further practice opportunities for current staff and help the new hires integrate into the code team. Simulation training will be scaled to include the hospitalist and surgical teams for peri-code and code scenarios. The focus will be on optimizing organization prior to the code team arrival. Simple steps of basic life support, such as obtaining the crash cart, beginning effective CPR, and placing pads on the patient, will dramatically improve the transition of care to the code team. The expansion will unite and standardize the institution's approach to codes and ultimately lead to better care for patients. In conclusion, effective code teams have been linked to improved patient outcomes in emergent situations. Simulation-based education is a tool that can be used to expose trainees to challenging scenarios in a safe practice environment. Frequent repeat simulation sessions will optimize overall skill and knowledge retention. By empowering the PA leadership role, we can address the institutional need for improved communication and organization during codes. Thank you for listening to my implementation project. Please feel free to contact me with any questions.